Hello, dear friends. Welcome to our online meeting with a specialist of IVMED Fertility Centre. Today, we have a special topic, a very interesting one. And today we will talk about embryology. And we have our special guest today, Olha Maliuta. She's our senior embryologist of IVMED Fertility Embryology Laboratory, ESHRE member, and also Master of Science of Molecular Biology. So today we prepared questions that you sent us before the webinar, and we will answer them today. Just to remind you that we have an active chat, so if you have any questions you can ask Olga, and we will discuss these questions after we answer prepared questions that you sent us before. And to remind you that this webinar will be recorded, and you can find our webinars, all our webinars on the YouTube channel, and this webinar also will be there. So let's start with our first.
Daria, I'm sorry. Firstly, good day to everybody. I'm happy to welcome you in IVMED Embryology Lab, and feel free to ask any question online, of course, and let's start.
Thank you. So we'll start with the first question. Are there any ways to prepare oocytes for IVF? Any vitamins, avoiding sports, etc.? Please, Olga.
Okay, it's actually a good question because many patients are very nervous about quality of their cells that we will obtain, and of course you can prepare them a little bit, like to do them more, like they will be much more
better.
Yes. So the first that you must know that the cells that we will obtain during punction, during oocyte retrieval, they start to grow actually 3 months before this oocyte retrieval. So you have 3 months to say no to any alcohol, nicotine, just reduce the amount of coffee that you drink. It's all will be like important to maturation of this oocyte. And of course, there are some vitamins that your doctor can prescribe you. You cannot like go to pharmacy and choose any vitamins. So just ask your doctor, because there are some good like supplies that you can take. About avoiding sports, I rather say no. So if you are like, you like to run, yes, like jogging, so just do what you actually normally do. So if you visit, if you do some sports like twice in a week, so just do like normal training. It will be bad if you will start to train more, or just you will say no to any sports. So just like daily routine, and all will be normal. So you just need to like choose just healthy meal every day. Yes, say no to alcohol and nicotine.
Thank you for your answer. Actually, it was a really important question because it's often asked, especially about sports, because a lot of patients, they're afraid that sports will do harm for the oocyte. But as Olga said, just do your daily routine as usual, but not too much sport, because too much is also not so good.
Not change this routine during like preparation, during these 3 months. It's just all.
Okay, thank you so much. So we will move to another question. It's actually a really big one and interesting also. I am 42 years old and I have 3 embryos, 6AA, 5CB and 3CB, which you recommend to transfer. 5CB and 3CB are frozen together. I want to transfer it to the surrogate mother.
Mm-hmm. Thank you for the question. In this age, the most, like the biggest problem is chromosomic abnormalities in embryos. So it's better, always better, to transfer like 2 embryos in this age, if they are without any genetic testing. But in this case, patient has one really good embryo, 6AA. It's totally hatched embryo. It's ready for implantation. And the 2 embryos with
Low quality.
yes, it's like questionable quality, and they freeze together, so you cannot like tow them together and choose second one to the 6AA. It's better to do transfer of 1 embryo 6AA. In like case of not successful transfer, first one, we will tow these 2 embryos together and will transfer.
Yes,
So
thank you.
Main strategy, it will be like this.
Thank you for your answer. And if you decide to do the program in our clinic with our agency, of course, we can ask embryologists before the embryo transfer what embryos to choose, what is it better to do PGD or not. So it's not a problem to ask before and to make a decision altogether with doctors, specialists. Olga knows we ask her a lot of times what to do, what to transfer, because patients are always worried which embryo is better to transfer. So we move to the next question. Actually, it's a really also interesting one. Can I check the RH factor of the embryo? Yes,
of course, now technology going like this, that we can do biopsy of 5-day embryo and check them even for one gene. Yes, we can choose like RH positive or RH negative embryos, and it's very easy to do. Of course, if you have history with like rhesus conflict, so it will be better to do this genetic testing. Yeah, it's very often we do it really often now, because many patients has problem with rhesus
factor. Yeah, actually yes, and we can do it in our clinic. It's not a problem. So our embryologist can perform biopsy, but also we can discuss that before starting the program, also during that. So we move to the next question, and actually we receive a lot of questions about low AMH level. And actually we had a webinar about low ovarian reserve, and you can also check our YouTube channel. And actually Olga took part in that webinar and told about OSAT quality, so you can check. And our question is, I'm 27 years old with AMH 0.97. Can I conceive naturally, or I need to do IVF?
Okay, it's a good question actually for doctors, not embryologists, but what can I say? This anti-Muller hormone will show your ovarian reserve. Yes, how many oocytes you have like in stock in your ovaries. But actually it will not say anything. Do you have ovulation every month? Like or maybe you have some problem with ovulation. In such young age, I think, even with this low AMH, you can have good ovulation every month. So it's just a question the doctor must check. He can do it with ultrasound monitoring, like to check, do you have really ovulation during her menstrual cycle? And also he will check some other hormones that will show, do you need IVF or you can conceive naturally? So it's a lot parts.
A lot of testing and checkup.
Yes. So just IMH will not tell you the answer. It's yes, it will be the answer like if you will undergo IVF. So this level of IMH will tell us how many cells we can obtain during stimulation and oocyte retrieval. So actually with such low IMH, we will receive not so many eggs, maybe 4, maybe 5. So if IMH will be higher, like for example, 2 or 3, yes, we will obtain much more oocytes. It will be 10 or 15. So it just will show to the doctor how many oocytes you have. But you need to check, do you have ovulation? Do you have everything normal with fallopian tube, uterus, and so on and so on?
There's a huge process, so it's not so easy. It's not so easy to answer that question. And I just have a little question for Olga. Also, as I know, AMH doesn't say nothing about the quality of oocyte. Also, so it's one more important question, because when you're 27 and when you're 42, it's actually the big difference.
It will be the different answers to.
Yeah. So. As usual, we can arrange a consultation with a fertility specialist, with our embryologist, so we can discuss the situation and to understand what you need to do, what the checkups you need to do, or if you really need to do IVF, or you can just conceive naturally just to try more time. So we move to the next question. What is the difference between PGTA and PGTM?
Thank you for the question. Actually, PGT, what does it mean? Yes, it's pre-implantation genetic testing. We can test our embryos before embryo transfer, and just to choose the healthy one. We can check the chromosomes quantity and quality of these chromosomes, how many we have chromosomes in embryos. And we have, actually, you can see this picture. It's shown this testing on day 3 embryos. When embryos are from like 8 cells, we take just 1 cells and check in the chromosomes. But usually we do this testing on day 5 embryos, on blastocyst stage. And for example, blastocyst will have inside, let's say 100 cells. We will take 5 of them and we will do testing. And this testing can be for regular abnormalities of chromosomes. This means PGTA. So we will check all like all genome for some big changes, for some translocation of chromosomes, for some like losing of part of chromosomes. It's called deletion. So we can check all genome, but let me explain. We will see these abnormalities on size, like they must have size more than 2,000 nucleotides. It's called like 2 megabase. Smaller problems, smaller translocation or deletion, we cannot see with this testing. But actually, it's very good technique because you can check all chromosomes for these huge abnormalities. PGTM, it's monogenic testing. So if we know that patient has some genetic history in his family, yes, like someone is carrier of genetic disease, and this disease like related to just one gene, yes. For example, it's cystic fibrosis. So we can check just this gene and to be sure that the embryos will not have any mutation in this gene. So like parents will not give to the child this mutation if of course, if parents are carrier of this mutation. So if we take this biopsy on day 5, now our technologies can provide you both this testing. So we can send one sample, this 5 cell, for example, even for PGTA, and to check all chromosomes, yes, and some maybe 1 or 2 genes. Even we can check, like rhesus we can check check this cystic fibrosis and so on and so on. So it's,
we can do it at the same time, right?
yes, now we can do it because science is going like further, so we can do it now, yes.
Actually, it's really great. So it's really great. So with PGTA, you can check all the chromosomes, and in PGTM, you can check only one. Also, for example, hearing loss problem is really common, and we have patients who wants to check the embryo for this special gene for hearing loss. So yeah, it's actually great that we can do all together and check everything. So
yes, and I will add something for PGTM. If patient have some rare mutation, like not major mutation in population, before this embryo testing, we will need to have a blood sample from carrier, like from parents, because we need to do some setups of lab equipment and to check like which type of mutation we will search in the embryo. So some rare mutation, we will need blood sample of parents. It's also important, yes.
okay, thank you. So we move to the next question. I am 30 and I had egg retrieval several times, but due to low AMH, I only received 5 eggs and had 3 embryos 5th day. I also had egg donation and I have 10 embryos 5th day. Can I transfer together my embryo and egg donor embryo? I think it's not to surrogate mother, is to
The patient, yes.
to the patient. Yes.
Okay, it's like difficult situation, of course, if it's if patient has several time like IVF cycle. So actually like what's the main purpose of our strategy? Usually we will recommend to transfer just 1 embryo for patient. If it's young patient and it's 30 years, it's young patient. If it's first trial, we will recommend to transfer just 1 embryo. But if it was several IVF cycle and without result, of course we will transfer 2 embryos. But 3 embryos we transfer in just rare occasion. It's not so good to transfer 3 embryos because it's high risk of like
Twins and triplets also.
Yes,
Yes.
so it's hard. So let's say we will transfer 2 embryos. So our recommendation will be to transfer 2 embryos of this patient for the first time. In case if it will be negative, first one transfer, so yes, we can transfer 1 embryo of the patient and 1 donor embryos. We can transfer together and it will be all okay. It's like they will not have some fights with one with the
Conflicts together,
yeah,
yes.
so it will not have any damage to transfer or to the embryos. Yes, of course, we can transfer patient embryos and donor embryos.
But also, if our patient watches this webinar, we also need to know the quality of the embryo. Also, it's also important to understand which is better to transfer. So we need more information. So I just remind you that we have an active chat, and if you have questions, you can ask them. And if we will need some details, we will discuss that. So the next question is, my husband and I are planning IVF next year. Is it necessary to do karyotype testing, or can we just test embryos? We want to do NGS.
Thank you for question. This next generation sequencing testing patient want to do, and it's actually this PGTA techniques, yes, when we check all chromosomes for some, like bigger abnormalities, for some rearrangement. We can also check like trisomy of chromosomes, some monosomic situation with chromosomes. So mostly, yes, with NGS you can test embryos for like the biggest part, the biggest amount of these abnormalities. But if you have some rare translocation in your chromosomes, like maybe two of your chromosomes just stick together, like make the fusions, it will not have some effects on your health or your phenotype, or you just like with this fusion chromosomes that fuse, you actually live like normal and healthy human. But maturation of your like oocyte and sperm cells will be problematic if your chromosomes are fused together. And we call such like rearrangement of chromosomes, it's actually it's balanced genotype. So you have 23 pairs of chromosomes, and all is normal, all is super. But actually this technique NGS will not show you that your chromosomes are fused, or you have some translocation of chromosomes, like your like chromosomes just take part of one and another. So like one chromosome has a small piece of the other chromosomes, and this other chromosomes has one piece of this chromosome. They like change parts of each other. So better, actually better to do karyotyping. If we will see such situation, we can do like specific NGS. We can ask laboratory to do testing like with high resolution for this region, actually for this region, to be sure that embryos has good chromosomes, that he didn't lose any part of in this region, any mutation happen in this region, because this region become like more sensitive for rearrangement. It's actually, it's a rare situation, but if you want to do genetic testing, actually, better always to have karyotyping. It's the main strategy for all patients, because if we test these embryos and we searching for some problems, we must be sure that in your karyotype all is normal, or we will know what to search precisely. So yes, better to do.
Thank you for your answer. Actually, in some countries, it's really hard to do karyotype testing. You can do that in our clinic. It will take some time, up to 3 weeks. We can do like speed test also. But yes, it's actually it's possible to do it here, but we will need to do some to wait some time to get the result. But our embryologist will have a clear picture, what to check, what to do, what to see, what to search in the embryos during the testing. So our next question Do you do mock transfer? Is it useful? My doctor in USA recommends, but I'm not sure if I need it.
Yeah, thank you. Mock transfer, it's like some testing. If patient has some problems with cervical channel, and during embryo transfer, we need to go through this channel with very thick silicone catheter. And actually, if it was some treatment on cervical or some surgery patient had on the cervical, it's better always the doctor who will do this embryo transfer will check, is it possible to go through the cervical channel with the silicone catheter, because it's he's very soft, you know, it cannot. If channel will not be so wild, yes, like big, sometimes this catheter cannot go through the cervical. So yes, if doctor knew your history of treatments that you had before, actually better to say to doctors who will do transfer that you had some treatments that your doctor recommends the smoke transfer, and then doctor will decide can he go through cervical or cannot. Actually, in our clinic, we had some difficult situation that doctor cannot go through the cervical because it was only even this patient had some hysteroscopic surgery, like to make this channel wider, but it didn't help. And in our clinic, we did this transmyometrial transfer. When we use like needle, we was going through muscles, through uterus muscles even, like myometric, and we transfer this embryo precisely in the uterus. Of course, patient was under anesthesia, was seduced, but it can happen. We can solve any problems, but doctor needs to know that you had some treatments before, and he needs to check cervical channel. So it's better to say it to the doctor, and he will decide to do or not to do.
Okay, thank you for your answer. And as I remember, we had pregnancy after that special technique, right? So
yes,
really common, not common situation, really difficult. And we had pregnancy. Our head doctor made the procedure, and we're actually really proud of that, and happy for our patient that despite the fact that it was really difficult situation, but still we have pregnancy. So
yeah, and finally, because patient has so many trials, and it's just a success.
Yeah, success for all of us. So actually that, wait, sorry, I just need to open my presentation again. We have a last question. We want to do surrogacy with egg cells. My husband did sperm tests. The results are following: DNA fragmentation 37%, morphology 1%, motility 12.6%, concentration 58.2. Are there any chances for us to have a baby? And I can see the ending of the question. Does my husband need to do any to take any medications and so forth, to have any treatment?
Thank you for the question. According to this spermiogram, it's actually, yes, the sperm has some problems because it's teratozospermia. The morphology is really under question because normal sperm, we can find more than 4% of morphology good sperm, yes, and here we have just 1%. Fragmentation is a little bit higher, and it's not normal fragmentation. We say that healthy patient has up to 30% of fragmentation. It's a little bit higher, but I will say not so critical. Actually, with such a sperm, we will highly recommend to do genetic testing of embryo, first of all, because we must be sure that we will transfer good embryos and the sperm will not add some chromosomic like abnormalities, yes, we will not have some abnormalities that avoids like sperm quality. Yeah? We also will recommend to do some special technique for choosing the right sperm. Maybe it can be microfluid sperm sorting, the new technique that can provide us good not fragmented sperm cell. So yes, we can think about this. About patient like preparation to to given the sample during for conceiving, yes, it's better to talk with some andrology doctor, of course. And actually, it's the same recommendation as to women. You need to prepare for conceiving, also like avoiding alcohol, avoiding like high temperatures. Do not go to some sauna or else. Reduce the amount of nicotine, and also you need to prepare for this procedure, like it's better like also 3 months you must do all of this, because spermatogenesis usually how to say it, sorry.
You can say it in Ukrainian, I can translate, it's okay. It's evening.
Yes. Huh? The time of spermatogenesis, it's 72 days. So it's like common duration of these processes, but actually it's 3 months. We will count 3 months of healthy food, and like after the consultation with andrology doctor, maybe also you take some treatments or vitamins or so on and so on. But actually, we can work with such a sperm. I think it will be not the problem, and we will choose we will obtain and choose a good embryos. Yes,
it's all possible with treatment and preparation.
For such a low quality of sperm, actually we work for solving such a problem, you know. We do ICSI, we choose the precise sperm cell, so yes, we can solve this.
Okay, thank you. So that was our last question from the presentation, and I need to check our chat if you have any questions, and we have them. So it's a question about, I think, the vitamins. It's CoQ10 as preparation vitamins to check. I think it's about, yes, it's Q10 vitamin. Is it helpful during the preparation? And it's helpful for also because now it's really popular vitamin. It's like it's you buy it everywhere, but
actually,
is it helpful or not?
I'm sorry, but I cannot answer even like such a question because I'm not a doctor, you know. I'm a biologist, I am embryologist, so it's a question to your doctor. Doctor knows what you can take or what medicine you cannot take, so better ask this question to your doctor. Sorry, I'm very sorry.
Yes, actually, because your doctor sees the whole picture, he knows your medical history, and before you take any vitamins, you need to check the level if you really need this vitamin or not. So actually, it's a better question for the fertility doctor, and everything depends on your personal situation. We can arrange a scalp consultation with a fertility specialist and discuss that what vitamins you can take for both sides, for women, for men. And so we have also an andrology specialist and urologist in our clinic. So it's not a problem. You can be at home, arrange scalp consultation, and contact with our specialist, and to find the better way for preparation for you. The most important part is to, as Olga said, that you have like 3 months of preparation just to start before, not to wait until the last moment. So it's really important. Actually, we have a lot of patients, and it's a really common situation, and sometimes it's really hard to, for example, get a good embryo and so forth. So we check our next question. What day do you prefer to freeze the embryo to have them tested and transferred to the surrogate mother?
Thank you. We prefer to freeze all embryos on day 5 or on day 6, because we have such situations that the growth of embryo like a little bit different. So some embryos we can freeze on 5 days, some embryos need them a little bit more time, and we will freeze them on 6th day. And if we tested them, we also prefer to do biopsy of material on day 5 and day 6. Because actually, on day 3 embryos, when we take 1 cell from 8, it's like 20% almost of the embryo. It's a little bit it's much higher harm like to the embryos. If we take like 5 cells on day 5, it's less harmful for embryo, and we can have better like testing results, like a complete picture of this embryo, and better to do it in 5 days.
Okay, thank you for your answer. We have the next question. I'm 37 years old and I have 5 blastocysts, all PGS 24 normal, grades 4BB, 4BB, 3BC, 4CB, and 3BC. I have had 5 previous PGS normal embryos transferred and nil pregnancy. I'm planning to try surrogacy. Which embryos would you suggest to transfer first, and how many?
Thank you for question. For me, it's better to transfer this 2 embryos for BB for first transfer, because it's not AA quality. It's not like the better quality of embryos. They are good. Yes, good, but not perfect, just let's say. So better to transfer these 2 embryos, and then to decide. Maybe these 3 embryos with BC or CB quality, actually we can transfer 3 of them. Because with such questionable quality, we can do this transfer of even 3 embryos. Of course, it will be decision this decision will make also doctor with our embryology advice and with like your view on this situation. But yes, my recommendation is to firstly to transfer this to 4BB embryos.
Okay, thank you. The next question. Hi, is there a reason why we get 2 blastocysts from 10 eggs? Actually, it's really interesting and important question.
10x if you was undergoing like oocyte retrieval after stimulation, yes, and during this oocyte retrieval we have 10x. After this punction, after 2 hours after this punction, we will denudate this cell. We will clean cells from cumulus granulosa cell, because you know our eggs do not goes by themselves. They have they accompanying with some other cells. So we will clean them after 2 hours, and we usually check how many mature cells we have. We have like different range of oocyte like maturity. Yes, we can fertilize only such cells that call M2. They almost finished their second meiosis division, so they are ready to for fertilization. Also, if we can see like M1 cells that finish just only first, or not finish, they just start the first meiosis division, or even GV cells like germinal vesicle cells that they don't start this final maturation procedure. We cannot fertilize them. So it's a question how many mature cells was from this 10 eggs. Also, it's a question how many this M2 cells was fertilized, how many 2PNs we saw on the first day, like how many zygotes we obtained. Actually, the normal blastocyst formation range, it's about 50%. We must have 50% of blastocysts from zygotes. We will not count from eggs that we have. We will count from this fertilized eggs. If it's less than 50%, maybe on blastocyst formation, like was some причины, sorry, Dasha.
Reason?
Yes, maybe we had some reasons for this low blastocyst formation percent. Maybe it's some genetic problems in embryos, because especially in older age, after 42, 45, it's really hard to have normal genetic embryos. So maybe they just stop to develop according to their genetic, according to their genetic. So it's it can be a lot of reasons, and
sorry, we have sorry to interrupt you. We have an additional details to the question. All eggs do very well up to and including day 3, up to day 3, and then we start to loop them in day 4 and end up with 1 or 2 eggs, and I think it's
on day 4.
Blastocysts on day 5. Yes.
Yeah, actually, this embryo arrest of development on day 3, it's very common, and it will say to us that it's actually genetic problems, because till day 3, embryo works only on oocyte resource, yes, on oocyte proteins, on oocyte RNAs, like he used just what oocyte gives them. And on day 3, it's start activation of all genome starts in embryo. So their own genes become like start to work. If something go wrong in this activation, if some genes do not work appropriate, so yes, we see this 3-day arrest. in this situation, always like better just to check maybe genetic of these embryos, or maybe if like it's also a very big scientific problem, you know, like why they stop to grow, why they arrest. For us, we always like prefer to check even this arrest embryos. What was the problem with their genetic, but like all scientific papers say that maybe they have some genetic problems and these problems with activation of genome. So just
thank you for your answer. Actually, it's really hard to know the real reason, and as I understood, and maybe someday in the future we'll have more technology to know that better. But for now,
I hope. But actually, it's not so rare situation. We have some patient with such a problem, and this 3-day arrest, it's a huge, like our head pain to all embryologists. Yeah.
Thank you for your answer. So we have the next question. What is spindle? I think maybe it's about spindle transfer.
What is spindle? Yes, actually good question, because when we say that we have different type of oocyte according to this according to maturation, yes, and if we speak about M2 oocyte, actually it's not finished meiosis of this oocyte. It's not totally mature egg, yes. In this M2 oocyte, near zona pellucida, where we can see like polar body, first polar body of the oocyte, there is small spindle. It's actually all the chromosomes of this egg. And of course, if we have some problems with like cytoplasm of egg, or you had like a lot of IVF cycle and it was unsuccessful, there is one technique that we can take this spindle, all these chromosomes from your cell, and put it to the donor cell. We just take out the spindle of a donor, all genetic information from the donor, and we can put like spindle of patient cell, and like to change completely cytoplasm and all mitochondria that will have some like huge
impact.
Yes, huge impact on embryo development. And we can obtain embryos with just patient genetic, but with new good cytoplasm and mitochondria. Yeah, so we can work with even with this spindle, with this genetic material of oocyte.
So you just use the donor spindle, but the whole genetic is from the patient. So
yeah.
If you want to
plasm from donor, yeah. Mm-hmm.
Yeah. So if you want to save your genetic material, but your cells need you need some help to grow embryos. So or you have mitochondrial diseases, as I understood also. So we can do that procedure in our clinic. But before that, also you need to have recommendation from the specialist, from the doctor, from the embryologist. First, it's not like a 5-minute decision to do that, but you can keep your genetic material. Is really good for those couples who don't want to do egg donation. So do you know if pronuclear transfer is best for if there is a genetic egg problem with regards to extra chromosomes in the PGS results?
Yes, it's thank you. It's a good question, because actually this pronuclear transfer or the spindle transfer will not solve all genetic problems with oocyte of patient. If you say that all the patient are like after 38 years or 40 years, they have higher risk of chromosomal abnormalities, actually we will not change this fact, yes, because we will work with this genetic of oocyte. It can help just in with cytoplasmic problem, but there is like 5 or 10% possibility that it will help to, this transfer will help to do like embryo repairing, because you know our embryos can repair themselves. Sometimes we can. It was one case not so late in our clinic that we had like anomaly embryos after 3-day biopsy. We take 1 cells and genetics says no, it's anomaly embryos, and we decide to redo this biopsy on day 5, and trophectoderm show that this embryo are just normal. We saw like monosomic abnormalities on day 3, and on day 5 embryo just repairs themselves. It's not so huge percent of such procedure, but it can happen. So actually that's why we prefer to do testing on day 5, because during this 5-day embryo can do some changes. So actually we will not solve all the problems with oocyte genetics, just like few percent it will become better. So actually after this pronuclear transfer and spindle transfer, the first thing it will be like PGTA testing of your embryos, of course.
So PGTA testing for all chromosomes to check.
Yes, it's like must have after all pronuclear or spindle transfer procedure. Yeah.
Okay. Thank you for your answer. And so will be the last question from the chat. And if you have any more questions, you can send them to our email or visit our next webinar, or you can send us an email and ask your questions. It's not a problem. We will answer them later. And our last question for today, spindle and pronuclear transfer, will it be still our genetic, or this will now be a 3-parents baby?
Mm-hmm.
This is actually a really common also question, yes.
I don't know why they call like such babies like 3-parents baby. I really don't know, because my genetic, all these 46 chromosomes, the baby will have from mother and father, yes. It will be like parents genetic completely. The only thing why they call it 3-parent baby, because when we change the cytoplasm, in cytoplasm we have a lot of mitochondria, like organelles that provide us energy, yes, and this mitochondria has small her own DNA, because it also interesting, like biological question. This DNA contains just 37 genes. They work only in mitochondria, and they not affect like our phenotype, how we're looking, how our personalities. They just do not affect. They work only in mitochondria and provide us energy. So genetically, it will be 100% like your baby, just with different mitochondria. So that's all.
So it's like no 3-parents baby, it's 2 parents, but
different mitochondria. Yeah.
Different mitochondria. Yes. So thank you for your answers, for your detailed answers. I hope it helped our visitors to see more clear the situation, and also thank you for all your interesting questions. So we will end our webinar. Just to remind that it will be recorded, the recording will be on our YouTube channel. And thank you, Olha, again, and see you next time.
Bye-bye.